Okay, this is chapter 9.2. Let's just continue on with the first highlighted point here, that the greater numbers of opioid prescriptions in the 1990s and the 2000s set the stage for patients becoming at risk for opioid prescription abuse. Okay, so just to repeat what we were getting into last time, is that the prescription opioids were too easy to get, leading to overuse, over prescriptions, and dependency, abuse and dependency. As prescription opioids became more expensive and difficult to get, patients who had become opioid medication abusers found themselves attracted to opioid alternatives such as heroin, alternatives on the street, illegal drugs that you don't have to get a prescription for, that you're buying and consuming illegally. So there was if you've seen this in videos or in the textbook, that they're really that the pharmaceutical companies and the physicians bear a lot of responsibility for this epidemic that we have, because they set it in motion with the prescription drugs first, the abuse of those, the overprescription of those, leading people to get hooked to opioids. And then when they became difficult to get by prescription, then you start to go buy them on the street and participate in criminal illegal activity, buying illicit drugs. Now, in response to this epidemic that was prescription based, new recommendations were issued by the CDC, the Centers for Disease Control, including the following. And let's see, I've got 5 points here. So they changed their recommendations to try to get doctors to not prescribe these opioids to patients so freely, so liberally. Number 1, a close examination of a patient's prior history with opioid use. So you needed to look at, was this patient someone who had a history of abusing drugs? Hold on just 1 second. Oh, looks like I'm okay. So you need to look at the patient's history, because people who have a problem now are likely to have had one in the recent past. And so if there was a history there, it could be continuing now into the present. Number 2, consideration of opioid therapy only if expected benefits were anticipated to outweigh risks to the patient. So previously what had been happening is that the patients are in pain, they're hurting a lot. And so we know these drugs are powerful and effective, so if you could make the pain go away, and you ignore any downsides, you ignore any costs or negatives or potential negatives like addiction dependency, you're like, why not pass them out like candy, prescribe them freely? Because what's the downside? They weren't paying attention. Doctors were not paying attention to the possible downsides. Leading among those downsides would be addiction dependency. So they needed to weigh the costs, the potential risk, along with the benefits of pain, improvement in reduced pain. Number 3, prescribing immediate release opioids when starting opioid therapy instead of extended release long-acting medications that would increase the possibility of abuse. So that they found that these extended release medications were correlated with abuse and dependency, but these sort of quick, immediate release opioids, less so. So that was kind of included as a recommendation. Consider prescribing immediate release opioids. Next one, number 4. Prescribing only the lowest effective dosage. So taking a minimalist approach. What's the minimal smallest dosage that we can prescribe for the patient that will still have some effectiveness? And maybe it wouldn't make the pain go completely away, but it would make the pain more bearable, take it down to a more acceptable level, at least take off the hardest edge of the pain if it didn't completely alleviate the pain, 100%. So taking this minimalist approach. And finally, number 5, scheduling follow-up evaluations to assess any long-term abuse problems. So needing to continue to monitor the patient after the short-term treatment to find out if any problems, longer-term dependency problems had occurred. So this follow-up idea, because a lot of times these folks were not following up, so the patient was developing dependency problems, and the doctor, who just kind of had a short-term focus, didn't really know that what was happening to the patient as time went by. In 2017, the American College of Physicians published a guideline for the specific treatment of back pain that included drugless remedies such as yoga, acupuncture, massage, and spinal manipulation as first-line therapy. Opioid medications were recommended only as a last resort. See, so again, it's kind of easy to fall back on to rely on medications. A pill is easy. And certainly the patients want immediate relief. So pills are popular with patients too. But that, when you take that kind of approach, it ignores all of these alternative therapies that don't have the downsides, that may be a little bit more effort or maybe a little bit less effective or less powerful, but they don't have dependency issues that go along with them, like these opioids. So again, there was a shift in thinking that instead of kind of going to the opioid medications quickly or like first line of defense, only use those if nothing else was working. So in other words, as a last resort. Meanwhile, heroin itself was becoming considerably more dangerous. Around 2013, the synthetic opioid fentanyl, approximately 50 times more potent than heroin, was being reported by drug control authorities in dramatically increasing numbers of confiscations, either mixed with heroin itself or sold, inaccurately as heroin. So now let me make a couple of points about that. Larger points. Point number 1. This has been the history of drugs in general in the United States, is a tendency towards purer, stronger, more intense versions of the drugs, of different types of drugs. So this has been a serious problem because the purer the drug, the higher the concentration of the drug, or drugs that are just the type of drug that are much more powerful, you're going to get more addiction, you're going to get more dependency. And so this is one reason why we have a current problem, is that the drugs are so concentrated and so pure, so powerful, that causes problems, dependency, and possibly overdose and death. So that's the number one big point that I want to stress, is this sort of escalation of the problem over the decades, which I don't know if I've stressed enough in this course or the textbook has, but that's definitely something that we want to stress here. And also, let me stress another point that I don't think that we've kind of driven home adequately in this course yet, and that is the idea that this flew under the radar for a long time. Yes, maybe in 2013 you might have had drug control authorities, certain individuals, certain people who do this for a living, knew about the appearance of fentanyl. But really, you had, I would say, at least a decade of a lot of people dying, overdosing earlier on, not so much from fentanyl, but then eventually fentanyl. And it was not really seen as a national crisis that got the public's attention. It wasn't in the news a lot. It wasn't something that people talked and discussed a lot. You didn't get legislation passed or reforms. It would completely flew under the radar for years, at least in terms of public awareness. Maybe the authorities knew about it, but we sure didn't get the message. And so that was a big public health failure was that years went by and you had all these young people overdosing and dying, and it just was not registering with the public consciousness. So that was a real failure, a real tragedy, and we're sort of still reaping the consequences of that now. The potency of fentanyl was so much greater than heroin that a mere 2 milligram dose of fentanyl would now be potentially lethal to humans. So with fentanyl, we're in a completely different game here. We're on a completely different level because of its intensity. While fentanyl has been available since the 1960s, so this is not a brand new drug in terms of being invented. It's been around since the 60s as a valuable Schedule II opioid medication. So we're talking here, we're talking legal, we're talking prescribed, we're talking used by medical professionals. There began in the 1990s signs of its diversion to availability as an illicit drug of abuse. So, but we're talking here small signs in the 1990s. But there's drugs that get developed, they get used a lot for medical purposes, legally prescribed by doctors. But that can, at some point along the way, can drift to illegal purposes. It gets in the hands of the wrong people and starts to be produced illegally, criminally, and distributed and sold on the streets. And that, who knows when that happens? It kind of depends on the players, the people who are willing. The people who know the chemistry of this and are willing to begin to turn it into a criminal enterprise. The more significant impact on opioid abuse, however, came from the influx of illicit or illegal fentanyl manufactured in China or in Mexico and then smuggled into the United States via Mexico. So this is very much connected to an international trafficking, drug production and trafficking set of operations. By 2015, the DEA reported estimates of confiscated opioids containing fentanyl to be more than 20 times higher than 2012, only 3 years earlier. So you begin to see in the teens there, mid-teens, this large numbers of fentanyl appearing. Again, still underneath the radar for the public, although professionals were becoming more and more conscious of this problem. Nearly 1 out of 7 confiscations of fentanyl-contaminated heroin in 2015 was traced to only 2 U.S. cities, Cincinnati, Ohio, and Augusta, Maine. So again, we're seeing in those early to mid-teens, and we're beginning to see signs of the spread of this fentanyl. In 2017, about 3 out of 4 individuals who died of an opioid overdose and about 2 of 3 individuals who died of an overdose from any drug were found to have tested positive for fentanyl. So it takes over. It takes over what was previously overdoses being dominated by prescription opioids or street heroin. Now we begin to see fentanyl overtaking that because of its lethal properties. Let's see. Looks like it's wanting to give me the whole page here. Fentanyl has been identified in overdose cases involving cocaine and methamphetamine as well as other illicit drugs. So of course we see that it's being mixed in with a lot of other drugs to sort of enhance the high. Fentanyl is very cheap. You don't need much of it. And so it can kind of substitute or take the place of other drugs, or it could be disguised. It could be sold as if it's other drugs that people like. So there's a lot of deception and that sort of stuff that goes on as well. Making matters substantially worse, new modified formulations of fentanyl, called fentanyl analogs, a term you should know, have recently entered the illicit opioid market, introducing even greater peril for the opioid user. So again, the danger continues to spread, to evolve, and now we're getting analogs, just a term just meaning variations of, or something similar to fentanyl. One particularly powerful fentanyl analog, called carfentanil, began to be reported in 2016 in contaminated street heroin, again getting mixed in with other drugs in several U.S. cities. Carfentanil has been available as an illicit synthetic opioid since the 1980s, but here again we're talking legal purposes, veterinary purposes only, anesthetizing large animals such as an elephant, musk ox, or buffalo. So get this, with a potency that is 100 times stronger than even fentanyl, and fentanyl, as we just discussed, is super powerful. So this is 100 times more powerful than that. An amount of carfentanil as small as 10 milligrams, that's just a little bit, is capable of sedating or even killing an African elephant weighing 15,000 pounds. So imagine what it can do to a human being. Well, imagine what it can do to a child. Very, very dangerous, very risky stuff. Let's see. Let's stop there. We'll continue on in the next segment.